My name is Hallie Lee, and today I will be presenting my findings on the current inaccuracies of how we measure the mitral heart valve and how implementing novel imaging technology could drastically improve our surgical outcomes. So it's no secret that heart disease is the world's deadliest killer, and the mitral valve is one of the most crucial parts. The job of the mitral valve is to ensure that the right amount of blood is traveling from the lungs into the left ventricle, which is the pumping chamber of the heart. Now, this job can be met with various challenges, the most prevalent being rheumatic mitral stenosis, which develops from repeated inflammatory responses to the streptococcal bacteria, which causes a buildup of scar tissue in the valve, restricting blood flow into that pumping chamber and reducing the amount of blood that can get into circulation. To unclog and reopen this valve, we use transcatheter mitral balloon valvuloplasty, which is a procedure where we inflate a balloon inside the valve to push back any scar tissue and enable adequate blood flow. But there is a challenge to this. The challenge is determining the ideal balloon size to both push back the scar tissue while simultaneously avoiding any tearing in the valve. To do this, we measure the patient's commissure-to-commissure diameter, or the diameter from corner to corner of their mitral valve, to figure out what the diameter of the inflated balloon should be. Now, to measure this crucial diameter, we use either the conventional formula, which is 1/10 of the patient's height plus 10, or echocardiography, which is an imaging modality involving patient sedation and probe insertion. However, both procedures have significant flaws in rheumatic patients. The conventional formula, which is widely accepted in healthy mitral valves, may be prone to overestimating the mitral valve diameter in rheumatic valves, which may have residual swelling from the initial streptococcal infection. Furthermore, the echocardiography is an invasive imaging technique unsuitable to high-risk patients. So now we have a formula that may not be accurate in rheumatic patients and an imaging device that isn't accessible to many of them. To combat this, my study examined if novel advancements in computerized tomography could enable its use as a non-invasive alternative to echocardiography with a greater accuracy than the current formula. If proven reliable, computerized tomography could greatly expand patient access to life-saving surgery and enhance surgical precision. Thus, my study sought to compare the accuracy of the conventional formula, echocardiography, and novel computerized tomography to determine if 1. The formula is inaccurate in rheumatic patients, and 2. If non-invasive computerized tomography provides similar analytical and procedural outcomes to invasive echocardiography. To do this, I conducted a 2-part retrospective study, narrowing down 96 candidates to 55 eligible patients, 40 in a cohort that underwent the normal invasive echocardiography before their procedure, and another 15 who underwent trial computerized tomography. For each, I built a clinical profile with 3 parts. Patient characteristics included age, height, sex, weight, Wilkins score, which is a patient's likelihood of having a cardiac event, and history of atrial fibrillation. This was just to see if there were any confounding variables between the cohorts. For the next part of my study, I compared the commissure-to-commissure diameter between the formula, echocardiography, and the computerized tomography in the 15-patient cohort to see if all the measurements aligned. For the second part of my study, I assessed the procedural outcomes between the patients who used echocardiography versus those who underwent computerized tomography to see if there were any significant differences. I used mitral area, which is the opening of the valve, size, mean mitral gradient pressure, which is blood flow speed, and mitral regurgitation, which is any backwards blood flow. I collected these values from 128 de-identified cardiac scans through TomTec analysis, where I froze frames at end diastole, so when the heart is expanding, since this is when the diameter is easiest to measure. Gradient pressure and regurgitation data came from prior analysis and patient records. Now for my results. For patient characteristics, the thing to note here is that there are no significant p-values, meaning the cohorts echocardiography and computerized tomography are statistically similar. Okay, so here are where my results get really exciting. The major breakthrough? The conventional formula is failing. My analysis revealed no correlation between the conventional formula and echocardiography-derived commissure-to-commissure diameters, with an R value of negative 0.17 and a p-value of 0.54. If the formula were accurate, it would align with the invasive imaging, but it doesn't. This suggests that the formula is unreliable for rheumatic patients and should no longer be used. While past studies like Tastan et al. In 2016 found minor discrepancies, my findings show a much larger gap. The likely reason for this is rheumatic patients have unpredictable inflammation, distorting valve structure and leading to consistent formula overestimations, which is what we saw. Since the conventional formula fails in rheumatic patients, we need a better approach, and my next finding delivers exactly that. I compared computerized tomography imaging measures of mitral valve diameter and echocardiography, and the results were amazing. A strong correlation of R equals 0.74 and a p-value of 0.0017 confirms that computerized tomography provides similar analytical accuracy to the invasive gold standard, validating computerized tomography as a powerful non-invasive alternative. These findings build on prior research showing that computerized tomography is precise in the left atrium and aorta, and the major reason for this is likely the advancements in computerized tomography now allow us to look at hemodynamics, or the heart in motion, so we can capture that end diastole. To further validate computerized tomography, I compared surgical outcomes between echocardiography and computerized patients. The results: no significant differences in mitral valve function with p-values of 0.12, 0.67, and 0.35 respectively. Again, this is a huge confirmation, meaning that computerized tomography can reliably guide surgery just like echocardiography, but without the invasiveness. Thus, my study uncovered 3 critical findings. 1, the conventional formula is not accurate and should not be used. 2, computerized tomography is both correlated strongly with echocardiography and does not sacrifice any surgical outcomes compared to using echocardiography. Finally, my study had a few limitations. Mitral regurgitation classification varied between clinicians, so potential subjectivity, and my computerized tomography cohort was very small. Future research should explore these findings in a larger randomized study comparing between echocardiography, computerized tomography, and the formula to further validate computerized tomography's use as a non-invasive alternative to rheumatic patients. Thank you.